Welcome to the Work Inspired Podcast. I'm your host, George Lucas Pfeiffer, and on today's show, we have a first for the podcast. Now that we're almost 12 months into the COVID-19 pandemic, I thought it was about time that we spoke with a physician so that we could better understand how leaders in healthcare are innovating to deliver higher quality care that's more accessible and more effective than ever before. Dr. Rick Bone is the Senior Medical Director of Population Health at Advocate Aurora Medical Group. Today, we'll discuss value versus fee-based care. We'll talk about pandemic response and vaccine distribution, and we'll also explore some of the exciting new technologies that are reshaping healthcare in our country. I hope you're ready to learn a lot because our show starts right now. Dr. Rick, thank you so much for being on the show. It's such a pleasure to have you on. You're the first physician we've had on the Work Inspired podcast, and really excited to hear some of your thoughts and perspectives, especially given the current situation as we record here in early 2021. Thanks for being here.
Totally my pleasure, George. Thank you so much for the opportunity. Looking forward to it.
First of all, as I was planning for this, I thought, Dr. Bone, what a great name for a doctor. I'm sure you hear that quite often, but tell me, who is Dr. Rick? Give me the cliff notes on your career up until this point.
So it's funny how I ended up where I am. My significant other was a nurse who then decided to go to law school. And I was finishing my GI fellowship at Rush, and she had one more year of law school to go. And I'm from Illinois, grew up in Oak Park, been around Oak Park, West Side guy forever. And she's from Wisconsin. And her attitude at Illinois is just too corrupt. Too many governors end up in jail, on and on and on. So she said, when I finish law school, we're going back to Wisconsin. As a dutiful significant other, I said, okay, fine. And I took a job that was supposed to be a year job at that point at Michael Reese Health Plan. Turns out in her last year at law school, she did a rotation at the Cook County State's Attorney's Office. And that's where she went after she graduated law school. And fortunate for her, or for all of us, 43 murderers are in jail because of her work at the Cook County State's Attorney's Office, which is a way to say that that one-year job turned into a sort of a career for me. So I was at Michael Reese Health Plan that was acquired by Humana, and I was in the staff model doing managed care for Humana. And then it was that staff model when Humana got out of the physician business. Of course, they're back into it now as the world just goes around and everything comes back and repeats itself. I was acquired by Advocate. And I tell people the best choice that was ever made for me was being acquired by Advocate. It's been a wonderful career, and I've been in the north side, south side, clinical practices, gastroenterology, and have always had some sort of administrative role. Right now, I'm Senior Medical Director of Population Health. Been there for about 3 years. Was on the south side doing most of the managed care. And the CEO came up to me and said, you know, we're getting a lot more of this managed care throughout the entire organization. We need you to sort of help us throughout the entire organization. So at that point, I had responsibility from Normal, Illinois, up to the Wisconsin border. And about 4 months after that is when we merged with Wisconsin. And so I work collegially with my friends in Wisconsin also on population health.
Wonderful. So you got to have that Wisconsin experience after all.
Absolutely.
Well, in talking to you, I can tell that you're passionate about just making sure people have good quality care, you know, across the board. And I think we're going to get into that a little bit in our questions here. But tell me, how do you define quality care? Because it's something that we're obviously, I mean, I feel like the medical community is more so in the spotlight today more than that I can ever remember, with vaccine rollout and with the COVID and the hospitalizations. As far as just setting the definition of the groundwork for what is quality care, what does that mean to you?
So I'll go back to something that Don Berwick taught me with the IHI out of Boston years ago, and it's the triple aim. And the triple aim is really improving the patient experience of their care. it's improving the health of an entire population, and it's reducing the per capita cost of that healthcare. And that triple aim was out for quite a while, and then he adapted it to the quadruple aim, which was maintaining the health being the health status, both physical and mental, of the providers and the team of providers. So it's evolved in the quadruple aim. So to me, quality care is fulfilling the quadruple aim.
And the way that we are set up here, I think for the majority of the United States, at least, is currently the healthcare system is fairly fee-based, right? I don't even know the best way to ask the question. I was kind of prepping this with another physician that I'm friends with that's in Wisconsin, and we were trying to say, is there a solution? If you're trying to switch from more of a fee-based model to a value-based model, is that even possible? And if it is, do you recommend that?
Absolutely. And actually, almost my entire career has been based on value-based care. I firmly believe in the capitated model, not the fee-for-service model. To me, the fee-for-service model, it's just the only way that you can do well is generating more and generating more and generating more. And you really, in a fee-for-service model, make more money when the patients are sick, because then they're in the hospital and they have the complications. And as sad as it is to say, when there's a complication, there's actually more money to be made. And I don't think we can afford healthcare in this country at the cost that it is now and the projections of where it's going to be. So I've always believed in a capitated value-based model. And I think you see that changing. If you see CMS and what they are pushing out, they have Medicare Advantage has been out there, 10, 15 years, and that's usually a capitated model. And people have done well on that, but it's also helped reduce the cost of healthcare. When you look at the ACOs, the accountable care organizations that either physician groups or physicians in hospitals have started under the auspices of CMS, the whole idea of that is to reduce the total cost of care. And then there is some additional dollars left over. Medicare takes their cut, which is fair. And then what's left over is for the providers and the health system, depending on how the system is set up. There's recently been something that the government is doing called BPCI-A, and it's bundled care improvement. And the A is now advanced. It's the second generation, but it's another approach to sort of trying to reduce the cost of healthcare while at the same time improving the outcomes for the patients. And really, the best thing we can do for patients is to keep them out of the hospital. Now, there's no question if somebody needs to go to the hospital, they absolutely should go to the hospital. But I think if you start looking at it, if you help a diabetic maintain their hemoglobin A1C so they're not getting the complications, and they're seeing a podiatrist to make sure they aren't developing foot ulcers, which can end up in an amputation, or they're getting eye exams to make sure they don't develop blindness, you're actually providing better care for the patient, a better lifestyle for that patient, and it's less costly if you don't have to take care of somebody who has a leg amputation. So it all kind of works best by making sure that we provide the best care for the patient. And as Berwick has always said, it always turns out that the best care is usually less costly care. So I firmly believe that this is possible. Medicare Advantage has increased in the country, used to be 10, 20% of the country. It's over 40% now, approaching 50%. And because of the way it's set up, there are additional benefits for the patients if they go under a Medicare Advantage plan. And I don't want to turn this into a Medicare Advantage advertisement, but you asked, is it possible to do value-based care? I absolutely believe that it is. And commercial programs are set up that way. Our contracts with the Blues, a lot of those on a per member per month cost. That's what the insurance company gets for the employer. They obviously take their percentage, as you would expect in any capitalistic society. But then they turn around and turn a certain amount of dollars over, and it's our responsibility to provide the care. I think one of the bad things or one of the unfortunate things that happened is when you think about the old HMO systems, people thought it was only restricting care. And care should never be restricted. But if you're doing the best care for the patient, in most situations, it's going to be less costly and everybody's going to do okay.
Yeah, it's interesting to just think about when you say patient, is a true value-based care model, is it starting before there's even a patient? I'm thinking about the employer and some of these incentive programs that are set up often through the insurance companies, whether they're wellness programs or, the stop smoking program, stipend gym memberships, that type of a thing. How early in the process does a model like that need to happen? And do employers have some role in that plan?
So I absolutely believe that employers have a tremendous role in that. Before you get to a Medicare Advantage program, which is for people 65 and over, unless it's a disability, all of those folks have been working. And the way you keep them healthy is that you provide all those sort of programs. We have a program that actually, if you follow everything that you're supposed to do, you not only are healthier, but you get paid $800 a year by the organization per dependent. So there's a financial to get there. But when you talk about gym memberships, why would somebody want a gym membership? Because if they're using a gym membership, they're active. They're not the couch potato as such, but they're really getting exercise. They're doing things, which is what we know need to do to keep healthy. 150 minutes of vigorous exercise a week is what we should all be doing. And those sort of programs help encourage that, which just lowers our blood pressure, lowers our overall weight, helps our heart stay in good shape, and helps reduce some of the lipid buildup that can lead to heart disease or vascular disease. So I absolutely believe employers should be involved in that. And I applaud those organizations that do have those wellness programs. And honestly, while it's a wonderful thing to do, if it lowers the healthcare costs, that's what we need to do, because we can't afford healthcare at the cost that it's at now. And our kids are going to have a real problem. So if you care about your kids, keep yourself healthy to reduce healthcare costs.
Have you found that certain things are more incentivizing or cause people to take action over others? For example, a financial incentive or increased awareness in education or just accessibility. What are the drivers that could usher in some change here?
I think we're all individuals and we all have certain things that make us interested. And there are probably some people that is saving a couple of $100 a year or getting a couple of $100 back will make a big difference. But there are others, the money isn't as important, but it's the feeling of being healthy, of being able to bend over to actually touch your toes versus not being able to do that sort of becomes a challenge. And there's certain people that affects. So I think a program needs to be multifaceted to try and attract as many people as it can. I think certain rewards work with certain people, but you need to have something that has a variety of things to attract everyone.
And I think one of the things that has become, it's in the spotlight now, is that each of us is in a bit of a different situation. You have someone living in a studio apartment in the city, and as we just went through this quarantine, the difference between that and someone out in the suburbs with a lot more space to be able to move around and to be active is significantly different. You've spent a lot of your career on the south side of Chicago, which I think for people that don't know is a different geography, a different demographic, often a different socioeconomic situation than is in other parts of the state and in the country. What are some of the challenges or some of the changes that you've seen happen over your career in that specific location as it relates to accessibility?
So I think that there has been in our organization, which is a faith-based organization, a realization that the organization has a duty to protect, to provide healthcare for all organizations. So Trinity Hospital, which is in a zip code that if you look at any social determinants of health, it's right up there. If you look at health challenges, if you look where COVID is, if you look where diabetes is, that zip code affects all of those. And Advocate has made a real choice to stay in that neighborhood and provide programs for that. Some of the changes I've seen is because of the support of an organization like Advocate, but it's not the only one that's in that area. It's community programs. There are a lot of community programs. There's a men's night talking about prostate cancer. There's a women's night specifically talking about breast cancer and the screening that's necessary for those sort of diseases. And then it's addressing head on the issues that have happened and that are unfortunate, are just wrong in our society. The experimentation on certain populations with disease processes that have happened, which causes mistrust. I think there's been a real push on the South Side to work in conjunction with churches to have conversations about, okay, that was a mistake. That's not what's happening now. Let's talk about these issues. Let's get them out in the open, and then let's do the right thing for everybody's healthcare. So I've seen a tremendous amount of interest putting into those programs. There's a food bank that Trinity sponsors, and plenty of other programs for the community that it's always been wonderful to be part of.
Mm-hmm. I'll speak from personally, but I know this from a lot of conversations I've had within my network, and I feel like in 2020, really for the first time, a lot of us really took a look at the healthcare system seriously, and it wasn't just that we, were part of having a child or sick and we're in the hospital. It was looking at ICU capacity and the number of available beds and some of the statistics and the challenges in our healthcare system. And now I think in 2021, as we look at vaccine distribution and that being really top of everybody's minds, because we're all thinking that that's the key to having us go back to some form of normalcy. What are some of the challenges? And then we can even tie this back into accessible health. If you think about how accessible is the vaccine, what are some of the challenges as far as the logistics of healthcare? Talk about the availability of a vaccine even. Is that something that you see is changing? Are we ready to kind of roll out wide-scale vaccine programs for viruses that we didn't even know about 12 months ago?
Well, I don't know that we're ready to roll. So yeah, we're rolling out vaccine programs. And one of the places that we're doing a lot of that is Advocate and Amani Church, or the United Church of Christ at the Amani Village, which is a program that the United Church of Christ has put together and has long-range plans. We partnered with them. So right there on their campus, we have a medical office, and we're doing all our COVID testing for the South Side there, not the only place, but one of them. And we're doing immunizations there, sort of bringing it into the neighborhood. But we've also done mobile vans trying to get out there to do either testing or immunizations. So I think that while a lot of organizations, especially faith-based, have understood this is an issue for a long time, I think what's happened with COVID is that people have really realized the disparities that have happened and said, oh my gosh, we need to do everything we can to try and fix this. And I think you're going to see a lot of programs in other organizations other than healthcare realizing we need to do things about these disparities. One of the areas that I've really been impressed with, and we actually have an office in this area, is in the Pullman area. There's been a real revitalization of businesses in that area. Now, there's no question the city has supported that. Private industry has supported that. We have an office there. The Blues have an educational office there. But I think everybody is realizing that we need to be part of the solution and do everything we can to make sure that the disparities that are there are being addressed on a daily basis.
You mentioned that being one change that COVID has ushered in. Are there other things that you think, lessons that we learned in 2020 that will have a lasting impact on the healthcare system moving forward?
Well, I think the open dialogue that we've had about the issues when you look at it by a zip code, are really focusing people that we need to do things there. But I think another thing that has really happened is virtual care. Virtual care was something that was talked about, not reimbursed. Not many people were doing it until COVID came along. And many organizations, not just Advocate, but organizations throughout the country, within 2 to 3 weeks, stood up tremendous virtual care models. Now, if you look at the Kaiser program, Kaiser is obviously a value-based model all within itself. But over 50% of their visits before COVID were virtual care. And the patients had a tremendous experience. And, and I think a lot of organizations during COVID were hitting the 30 and 40% mark. And we did. But I will say it's unfortunate. We're probably down to barely at 10% at this point. And to me, look outside in Chicago today. In the last week, we've had 12 inches of snow, and it's still snowing out there. This is a tremendous day to use virtual care to take care of patients everywhere, not just those that have problems with the social determinants of health. But you think of somebody who needs to take 2 buses to get into an appointment with their doctor. This is not the day they could do it. And it is a more efficient way to provide care for patients that are at home on a day like today. And honestly, you could look at somebody in Oak Lawn, Naperville, Orland Park, or Barrington, and nobody is begging to go out today. But if they had an appointment and they had the option for virtual care, I think we could do tremendous things. And one thing that I've really pushed with insurers in the local market who have heard it and are looking at it, a lot of insurers in their Medicare Advantage program have had rides, that they would provide rides for the patient, up to 12 rides a year. One way is considered a ride. So you have 6 round trip visits to see your provider. And we've had a lot of conversations that we need to take benefits like that and figure out how to get virtual care as a benefit for things like that. Because there's no question that there are patients that don't have a smartphone or don't have an iPad or don't have a computer. And obviously there are many multi-generational families where that equipment is available. But I just looked at some, I guess, technology the other day where somebody has it that you could actually do a virtual visit over a regular TV. As long as the TV has an HDMI cord, he has equipment that you can plug in and each actually do virtual care. And we're very interested in possibly doing a pilot to see how that could work. Because at least thinking about TVs, there's probably a TV in almost every house. So I think that there are ways, and I think what's happened is COVID has brought this to all light. We need to look at other ways of providing care, and virtual care is one of them. Drive-through care. One of the things that we did during the height of COVID is we had patients that were on anticoagulants, which means they're on blood thinners. And those have to be monitored, but those patients didn't want to drive into the facility. Now, obviously, this was in Chicago in April, May, and June, so it worked out a little bit better. But we actually had drive-through checking of your anticoagulation. And the pharmacist would go out to the parking lot, set up a little area. The patients would drive through, put their hand through the window, get their blood test, be told what to do, and as they drove away, they would be called and say, here's how you need to adjust it. So I think that has brought a lot of ways for people looking at drive-through. And we've actually experimented with, are there ways to, for want of a better term, turn a Jiffy Lube into a healthcare facility? Now, we haven't gotten there yet. The plans are in the drawing. It's a little more expensive than we were thinking. But there are places out there that do that. I went to the Orland Mall, and there is a drive-through 2-bay facility that you can actually drive in. They close the doors, and in your car, you can get your health care. So I think we're going to see a lot more innovative things happening because of that, because I don't think that COVID is going to be the only pandemic we're going to have. Now, it was 100 years ago before we had the last pandemic, but with travel the way it is and movement of people the way it is, I think that we're probably going to end up with situations that are going to be a little bit different going forward. And while everybody says we're going to go back to, I don't know we're going to go back to the way it was. I don't have a prediction of what it will be. I'll leave that all up for Fauci. He does a pretty good job of that. But I do think that we're going to have some changes to some of the things we do.
Yeah, it's very interesting. I agree. And if we haven't learned lessons from this time around, then shame on us, right? That's one of the opportunities here, is to change and to be better prepared for the next time something like this happens, knowing that it's probably going to be different than this time around too. You mentioned technology and the virtual. Very interesting that there is less adoption. You're right. It's freezing cold out here. If I could see a physician over a webcam, I would much rather do that, as long as I felt comfortable that was going to solve my problem. I wonder if maybe some of the adoption of that is more people just aren't comfortable with technology, or maybe it's a partners and providers type of thing. I'm not sure. Related to technology, though, do you see wearables and diagnostic technology, that like our smartwatches that monitor our health statistics, do you see that as part of the future of healthcare, where it's not so much of a scheduled appointment, but it's more of these little warning monitoring systems that we wear that can alert us when there is a problem?
I absolutely believe technology is there. And I'd like to address the question of, adoption of technology. I think that people are adaptive and smart. And so I've seen some organizations that really, when it comes to taking the blood pressure, the medical assistant will get on the virtual visit before and talk the patient through how to take their blood pressure. But anybody who takes their blood pressure at home knows you just put this on your arm, the machine does everything, and there are ways to electronically transfer that. So absolutely, I think we're going to see more and more of that. And I think we're going to see more wearables coming out. They're going to let us know exactly what's going on. Now, the first time it comes out, does it work perfectly? No. But you know what? Nobody took a Model A Ford or a Model T Ford and said, I'm going to live in this for the next month and travel across the country. But when you look at a nice 44-foot RV, all of a sudden, living there for a month and traveling through all the national parks looks pretty exciting. So I think we're going to find a way to adapt all of this technology, and it's going to continue. When you think back of, 20 years ago, a computer was in a box you carried around, or maybe it was 30 years ago. I'm dating myself a little, but, and now everything is right here in our little smartphones. I mean, there's more technology here than they went to the moon with. So I think your point about will there be more wearables that are going to help us with that? Absolutely. Absolutely. And it won't be perfect the first time. And there are going to be a lot of naysayers. And I think you're going to have a perfect bell curve distribution of your bleeding edge and then your early adopters. And those laggards are going to be there no matter what it is. I'm sure when it came to washing machines, there were laggards that said, what do you mean? Use this washboard over there down at the river. It works just great.
So you're saying that gone are the days that we'll have to walk into a hospital and fill out a bunch of paper forms. That's something to look forward to.
I would like to think so. I think that we've done a decent job of going electronically. My own personal opinion is that it's turned doctors into nothing more than data entry clerks, and we need to change that. We need to have all of those forms available that somebody can fill them out at home, and they only fill them out one time. It's not when you go to a different department, all of a sudden it changes.
Yeah. Yeah. And I wasn't even planning to ask you about this, but I think the other thing that's potentially on the horizon in the healthcare system is the use of automated or artificial intelligence to really be intentional about what you're using a human to do and helping to make the process of diagnostics and some of that record management more automated. It's interesting to see what computers are capable now of and We'll see. It's some exciting changes and somewhat scary changes potentially on the horizon. But I think
there's no question Dr. Google is not going to go away.
However, he's the worst one, though.
but I think that you're going to see other things happening. And actually, there was an announcement just earlier this week. There's a new company, I think it's Truvia, that Advocate and 13 other systems are part of. And it's taking de-identified patient data and then using that in a research to try and predict things. And there are a lot of things that you can do. When we discharge somebody home now, we have a ranking of what do we think the risk is of them being readmitted within 3 days and within 7 days. And if somebody has a high score, we throw all sorts of extra resources at them that we don't throw in somebody that has a lower score. Now, it's not perfect, but this is the early approach to AI. And absolutely, there are plenty of organizations that are working. And if you pull up the literature, everything has something from predicting lung cancer to predicting how somebody will respond with some other cancer. So there is a lot of that out there. Read an article on prediction of should you use blood tests for PSA screening for prostate cancer or an MRI, and the MRI being able to look at things and predict with an artificial intelligence. I think in the next 3 to 5 years, there's going to be a tremendous explosion of that. And I think the other thing, if people are comfortable with it, it's going to involve genetic testing. If you look at places like 23andMe and there's another organization called Helix and a few others who really take some of your saliva and then sort of can predict some of the diseases that you might come up with. And there's all the worry that an insurance company is going to now sort of blackball me. And I think we need to make sure those sort of things don't happen. But if you know that somebody has a predisposition to developing colon cancer or to developing breast cancer, and there's things that you can look at to make sure you're either doing early screening or figuring out what's the best prevention, those are the sort of things that are really going to help us to provide better outcomes for our patients in the future.
Yeah, my wife and I took the 23andMe test, and the amount of information you get back, and it's consistently developing too. You know, we took it years and years ago, but we still get updates as to new second cousins in Florida, or like a new gene that they found protects you from this or might have a higher increased risk for that. It's very fascinating. I know, though, that one of the concerns is the privacy piece of it. And that's something that we're thinking about now, even as we look at technologies for returning to the workplace, these automated temperature scanners that you walk into and they scan your eyes and instantly alert the facility if you've got an elevated temperature. How much of a legitimate issue is collecting medical related data from people? And we could relate this back to the wearables too. Is that a serious concern that we have to figure out a way to make sure that information is kept private and not sold to a third party or used in a way that I don't even know, because it's not like they're taking my name, although they are with the 23andMe, but the whole idea of data privacy and health privacy, how important is that?
Usually when I get into a conversation with folks like this, I start off with sort of a joke. The NSA already knows all this. Yes, so who are we trying to kid? Now, getting past that sort of attempt at a little bit of humor, I think that there are a lot of things that we need to do privacy-wise to make people feel comfortable. But honestly, when you look at the amount of information that's out there about any of us already, about our credit scores and about other things. I mean, something that really got me the other day, and I actually was a little taken back, Experian is getting into healthcare. It just had a little bit of a bad feel to me. Now, I don't mean this negative for Experian, but I think part of this is our issue of how do we feel about privacy? And then how much privacy is there really? And then I think we need to look at our legal constituents to say, what are the appropriate laws that should be there to make sure that privacy is there. But honestly, based on the hacking that Russian has just done on every one of our governmental computers, I'm not sure that we're ever going to be able to have the privacy that we had 150 years ago. But is that going to be worth the increased ability to provide and keep people healthy? I read an article recently where they're starting to talk about the idea that reaching 100 is not anything unusual. And if you go back 150 years ago, where you might be able to say, yes, we had privacy, but did you live past 45?
Yeah, exactly.
And I think that everything has a trade-off. Any of us in a relationship understand the idea of compromise. And so I think that those are some of the things we're going to have to grapple with as a society. But to me, being able to understand what we can do to prevent diseases or to treat diseases better is probably worth. Now, this is just one person's opinion, and I'm sure there are plenty of other people who don't agree that way. And maybe we figure out a way for them not to participate. But my guess is by the time their kids are old enough, their kids will say, maybe this is why I lost dad. And maybe this isn't the worst thing. But I think it's a societal question that we're going to have to answer. But I think we're going to be pushed to answer it sooner and sooner than what we are thinking is going to happen.
Well, I think it's a great opinion and certainly something to think on. So I appreciate the perspective, Dr. Rick. Let's end with a couple questions that are a little bit more personal to you. You've obviously had a successful career and really value your experience and your insight. What's a resource that you found valuable as a professional?
I always found societies, national societies. I'm going to mention two that I've been involved with a good part of my career. Something called Group Practice Improvement Network. And I've been on the board and led it for a number of years and other organizations. And it's healthcare organizations getting together with the absolute idea of sharing ideas. Everything was open to sharing. I'm a firm believer. I don't want to invent the wheel. I want to look at somebody else's idea and say, wow, you did a really great job doing that, and then implement it to help the patients that I'm working with. And the other organization is American Medical Group Association, AMGA. I think that working with colleagues on a national basis and going to meetings and learning and exchanging ideas has been one of the things that really has helped me to move forward. Because you come up with an idea and you bring it up to somebody, they go, oh, you're crazy. And then you go to a meeting and realize somebody's already done it. And you go, oh my gosh, one, I'm not that smart, because they've already figured out, one, not only it's a great idea, but they've done it, but that gives you the interest and the willingness to go on out there and learn from them and then do it. So again, I'm going to admit I'm a real believer in not reinventing the wheel, but taking anybody else's idea. Now, of course, you have to be a colleague, and it's not something that you're trying to monetize. But to me, in healthcare, we're trying to keep people healthy. So let's skip the monetization. Everybody is going to do fine. Let's do what we can, and let's learn from each other. So I would say going to society meetings and learning from colleagues is probably one of the biggest things that has really helped me in my career.
Great advice. We talk to a lot of different leaders from different industries and different, organizations, different C-level positions. But one question I like to ask them all is about leadership. Obviously there's leaders in every field, you being one of them. What's one quality that is descriptive of a successful leader, regardless of who they might be leading in what industry?
I think the one thing that I've always tried to do, and I think really is most important, is you need to make sure everybody understands the why of what you're going to do. You can be a leader and have a great idea, and if you just tell people to do it, Maybe they will, maybe they won't, maybe they won't quite understand. But if they understand the why and what the outcome is hoped for, all of a sudden you've got people that are banging down the door to say, let's get this done. Let's get this done if it's really the right way to go. So to me, what's really important for a leader is to explain the why. And then you hire a bunch of people smarter than you and you get out of their way. And of course, I'd like to think that's original, but that's a whole Steve Jobs who I, read a lot about. But I mean, I really believe that. You get smart people, you explain the reason why you want it done, and then you provide them with the resources and you get out of their way and support them in every way you can.
It's awesome. Well, you've already shared with us a lot of great ideas and interesting, thought-provoking concepts. If you were mentoring someone and you wanted to leave them with a word of wisdom or an idea to inspire a future generation, what would that be?
Have fun. If you're in a job and you're not having fun, you're not in the right job. But if you're in a job where you're having fun, it's not work. And you really enjoy going to work and you don't mind the extra time you might have to put in. And when the work's done, you go on out and enjoy yourself. And honestly, you're in a much better mood when you go home to the family. And you're able to relax on the weekend. You're going to lower your blood pressure. You're going to live longer and you're going to enjoy it. So to me, it's really important to have fun while you're doing that. Does that mean that there aren't days that just drive you crazy? Of course there are. Things don't go right, all that sort of stuff. But if you're in a situation where you're overall really having fun, it's not work.
Mm-hmm. Mm-hmm. Well, I've certainly had fun on this interview. It's been so enjoyable to speak with you. I do want to very sincerely say thank you for everything that you and the other medical professionals have been doing, especially over the course of the last 12 months, in helping us battle this crazy virus and pandemic. But excited to follow you and to see what some of these changes that we've just talked about come to fruition and in shape and form. But thank you for your time, Dr. Rick. It's been such a pleasure.
George, it's been an absolute pleasure. I've had a great time. Like I said, I've had fun.
Thanks for listening. If you enjoyed this conversation, please take a moment to rate our show. If you haven't already, be sure to subscribe to the Work Inspired podcast so that you don't miss any of the incredible guests we have planned for upcoming episodes. We'll continue to find the best and brightest minds in business so that you can learn, grow, and succeed, and so that we can all work inspired. Work Inspired is brought to you by BOS, a leader in commercial working environments and a Hayworth best-in-class dealership. Experience our 360 approach and discover the team, tools, and techniques required to navigate the complexity of your next workspace at BOS.com. If you have ideas, feedback, or would like to be featured on our show, please email podcast@BOS.com. Thank you for listening. This has been a Workspace Digital production. If you're interested in launching a podcast at your organization, please email info@workspace.digital for a free consultation.